My name is Tammy Vandermolen. I'm a family nurse practitioner, DNP, and I work over in Alton now. I've been with BJC from St. Louis for 23 years, so I've got a little bit of experience under my belt here. If you want to write down my email address, I know on the slides that I sent in, I didn't realize my email address was not on there. Pretty easy to find, Tammy Vandermolen, DNP@gmail.com. Sorry, my last name is so long. So I'm going to be talking to you guys about billing and coding, getting out of that 99213 rut. In primary care, most visits should likely be more of a 214 visit. And so this is me going to help you in achieving that 214 without a lot of additional work. Oh no, Eric, I hit the wrong button. Let's see here. All right. So I have no disclosures. Our objectives today are to understand the three key components of billing, recognize and identify how to document and support your level of billing, and understand how to bill for time.
Just a second, we lost the screen.
Did we lose the screen?
Oops.
Yeah. I get to give a presentation. Fantastic. All right. Okay, so the first thing that we need to do, and I know this sounds kind of trivial, is deciding what kind of patient type do you have. Do you have an established patient or do you have a new patient? And depending on what kind of practice you work in, that may be really easy. An established patient has to have been seen in your practice within the previous 3 years by either an APP or a physician. A new patient would be a person who's not received any services from your physician or APP in your group of the same specialty within the last 3 years. So where this can become a problem, I know I worked in a rural health clinic where we had a group. So I worked in Steelville, we had a group in Bourbon, we had a group in Cuba, and we had a group in Sullivan. We all had the same billing ID number. So if I was out of the office and somebody went and saw the provider in Cuba, even though that provider had never seen that patient before, that was considered an established patient because we all used the same billing ID number. So that's a nice thing for you to know if you work in a group type practice. This also, just to be clear, if you are primary care and they saw GYN or if they saw GI and they're still in your same group, that doesn't count. This has to be within your same specialty. So when we're looking at billing and coding, you've all heard AMNP coding. So what does that mean? There's 7 components that can be used to choose the level of services, but the most common ones we have 3 of, and that's what we're going to be talking about today. So the 3 key components of billing and coding are your history, your exam, and your medical decision making. We're going to talk first about your history. As a reminder, all charts need to have a chief complaint or else insurance can deny your payment. Also, chief complaint cannot just say follow up. What are you following up on? Are you following up on your hypertension? Now, your staff does not need to put in following up on hypertension, following up on diabetes. One thing is fine, but you have to have something in there. And then obviously, if they had a sore throat, that would be an appropriate chief complaint. So for your history, you have to include a chief complaint, your history of present illness, your review of systems, and your personal, family, and social history. And I'm going to go into each of these individually for you. So for your HPI, this is what the patient's coming in for. If they're coming in for an acute problem like I twisted my ankle or my knee hurts, the HPI I have listed here, if you make, I don't know if your EHR systems have a smart phrase, mine has where I can create a smart phrase, and I created this and I typed it in just like this, and mine is a generic HPI, and if I type that in, it pops up and it says location, quality, severity, timing, and I have all of this written out. So if I answer those questions, I know I'm meeting the HPI requirements for a level 4 visit. Just so we're clear, 4 or more of these addressed meets a 214 and a 215 visit, okay? So if somebody's coming in for a sore knee, you're gonna document that it is their left knee, that it's an aching pain, the severity is a 7 out of 10, and it hurts all the time. Even if you don't even discuss that the ice and ibuprofen is helping, you know, those are just some additional things. So you need to meet at least 4 of those for you to meet a requirement of 4 or 5s. Now, as far as your chronic illness visit stuff goes, we'll talk more about that here in a minute. But as far as the acute visits, I just wanted to make sure that if you guys make a smart phrase, or you know, whatever your EHR system allows, that's really, really helpful to be able to just have that and know, if I answer these questions, I've met my level for HPI. Your review of systems. Are you guys aware that to get a 99214 visit, you need to click 2 boxes, 2 separate sections, okay? You can't say that they're having no chest pain and no palpitations, because that would be in one review of systems section. But I ask all of my patients, are you having chest pain? Are you having any shortness of breath? That is 2 separate categories, and you literally only need to ask 2. I ask all my 12 and older patients if they're feeling suicidal, so that's meeting me a 3rd one. And if they're here for a sore knee and I'm happening to document, it will automatically pop over that they're having knee pain or those kind of things. So I can oftentimes end up with more than 2, but you need 2. That's it. 2 review systems to get a 99214 visit. To get a 215, you do have to have 10. Okay, and then only 2 are needed for a 203, and you need 10 for a 204 or a 205. So here's the things that you're looking at for that is your constitutional, your eyes, ears, nose, mouth, throat, heart, belly, GYN, GU, respiratory, musculoskeletal, your skin, neurologic, psych, endocrine, your lymphatic system, allergic and immunologic. So those are your review systems that you can choose from. But like I said, don't go crazy. I can go nuts. If you ask a patient, do you have this and do you have that? They're going to say yes to everything, and you're going to be in that room for an hour. Okay. So making sure that you're focusing, and you don't have to have all of that. 2 things are all you need. Your history. This is likely going to be started to be documented by your medical assistant. But in order for billing to be appropriate, this has to be documented last by you. So I have this on my wrap-up screen on my EHR is where I click this, because if I go in it and I'm looking at the chart ahead of time and I click on it, but then my MA makes a change, it does not count that I was the last one who examined that, okay? So like I said, you have to be the one who closes it first. In my EHR, they did an upgrade a few months ago and made it really nice that I cannot close my chart until I hit that reviewed button. And so I am now meeting all of those because I can't close my chart without it. It's been a blessing. I love it. So the next thing we're going to talk about is your examination. And again, I like to have a preset thing to where I know if I am doing my exam that I am going to reach that level of coding that I'm looking for. In primary care, I am not normally just seeing one body system. When you come and see me, I'm going to look at your eyes, your ears, your nose, your heart, your lungs, your belly, and feel your pulses and carotids. I do the same physical exam on every single person who comes in. And then if you have a knee pain, then I'll look at your knee. But you're going to get that same exam from me. And I know that when I click my normal exam, and then you can chart by exception, but if I click my normal exam, I know that I'm going to be meeting a 99214 or 99215 because I took this information from this kind of a presentation and I built my exam in there in my EHR and was able to do that. And I only clicked on the things that I know that I'm actually doing during my visit. So you can create that. And if you need to, enter one new item on your physical exam, maybe you weren't checking a pulse. and documenting it. I bet you're probably doing it, you're just not documenting. And so that's my goal here, is to make sure that I'm making this as easy for you as possible to be able to get in and out of that room, because we don't have an hour to deal with everything that we need to. So for your physical exam, there are two different means of being evaluated. You can either do body area or organ systems, but you cannot mix and match them. So this page here has the body areas on it, but most EHRs are set up for organ systems. I think this is probably going to look more realistic to you, having the constitutional and the eyes and the ears, nose, throat, cardiovascular, and all of those separate systems is how most EHRs are set up. So for your physical exam, this is looking at bullet marks, okay? So for your constitutional, we're looking at least 3 vital signs. I don't know any primary care office who's not getting height, weight, and at least a blood pressure or a temperature on a patient. So you're gonna have that. As far as general appearance of the patient, and this is where you're gonna say, the patient is morbidly obese, or, in acute distress, or any of those kind of things. So making sure that you're documenting on the appearance of the patient. I tried to put this up here for you. These are the things that actually count for bullets. When I'm looking at eyes, it doesn't mark if you're having all kinds of different, individual things. These are the things that you can document on eyes that are going to count for your bullets, okay? Because I know my EHR, it has a bunch of things that I can click mark on, but not all of those are going to count for bullets, okay? So your inspection of your conjunctiva and lids, are they icteric? Those kind of things. Your perla. And if you do an ophthalmic exam and you're looking at the discs and the segments in the back of the eye, that's things that you can document on. For your ear, nose, mouth, and throat, and just to be noted, a lot of this can be done on Zoom visits. I can see, when the patient's moving their head to the left and right, that their, neck is moving well. I can see their nose is not, having any blistering, marks on it or anything like that. I can tell if they're saying huh a lot to assess their hearing. I can, see their external ears if their hair is pulled back. I obviously can't, document on their throat, but you can do a lot of this via Zoom. I've been doing a lot of Zoom visits, and I'm still able to get a 99214 visit even out of my Zooms, okay? So again, external appearance of your ears and nose, your otoscope exam, assessment of hearing, looking up their nose and in their turbinates, looking at their lips, teeth, and gum. Are they edentulous? Those kind of things. And then their oral mucosa, salivary glands, and their palate and tonsils are all acceptable bullet marks for your ENT exam. For your neck, looking for crepitus and is their trachea aligned? You're going to be feeling for your thyroid and masses. For respiratory, documenting the respiratory effort. Are they having subcostal retractions? Are they, in no acute distress? Their percussion of their chest, feeling for tactile fremitus if you're doing that, and then the auscultation of the lungs. For chest and breast, inspection of the breast and palpation of the breast are both notable bullets. For your heart, I always laughed at this first one when I was first trying to do this, and it said that you can document for palpation of the heart. I'm like, okay, how exactly am I going to palpate that heart? And then I finally found where it said it was the point of maximal impulse, and it was like an aha moment for me. I felt really dumb at the moment. I was like, you know what? I bet somebody else is looking at that going, how am I going to palpate that heart? So auscultation of the heart, assessment of the lower extremities, doing your carotid, listening to your carotids, checking for abdominal aorta, bruits, checking your femoral and pedal pulses. Those all count for your cardiovascular. Another thing to note is that the lower extremity and pulses are counted under the cardiovascular bullets. I know in my EHR system, that's not where I find it, okay? I'm documenting under skin and musculoskeletal for swelling and pitting edema and those kind of things, but it doesn't count in that section. It counts towards your cardiovascular. As far as GI, I think this one's pretty self-explanatory. We're going to be doing the exam, looking for masses and tenderness, making sure, if you're percussing, over that liver and spleen, no hepatomegaly noted, looking for hernias. And then if you're doing an exam of the anus, perineum, or rectum, or doing an occult blood, you can get bullet marks for those also. Genital urinary for men, doing the scrotal contents, examining the penis, or if you're doing a digital rectal exam for a prostate. Females, we have a lot more, and so there's a lot more things that you can document on there, and I'm not going to go into all those for you. They're written out there for you. So lymphatic system. It is needed to note that you need to document lymph nodes in at least 2 or more areas. So neck, axillary, groin, your epitrochlear or brachial, and the arms, your iliac or inguinal or femoral, or your popliteal heel. If I have somebody who I am feeling their neck and I feel that they have swollen lymph nodes in their neck, I'm looking elsewhere. Let's lift up your shirt. Let's take a look at your axilla. Let me check your brachial area, and making sure that I'm not noting any other lymph nodes. And if they have an obvious sore throat and they've got postnasal drainage, okay, fine. You don't have anything else. We're good to go. I just don't want to miss a lymphoma. So for skin, looking for rashes, lesions, ulcers, feeling for indurations, nodules, is it skin tightening, those kind of things. So nice and easy for skin to meet those. Your musculoskeletal bullets. I always try to watch a patient either walk in or walk out of the room, okay? So even if it's not right at that moment that I'm documenting their gait, I am able to document their gait because I have seen them either walk in or walk out. So that is a big one for you. You are going to be looking at your nails. Are they having any clubbing, any cyanosis, or anything like that? And then as far as exam for joints, bones, and muscles, 1 or more of the 6 following areas. So you get a right upper, a right lower, a left upper, a left lower. You get your spine, ribs, and pelvis all in one section, and you get head and neck in another. For these, you can document on inspection and palpation. Are they having any crepitus? Are they having any tenderness? How's the range of motion? Noting any pain or crepitation on your exam, or contractures. You can document their stability. If you're doing your Lockman and drawer testing, you're looking for your subluxation or laxity. And then looking for muscle tone and strength, and noting any abnormal movements or any atrophy noted. So those can all be addressed and counted for bullets on your musculoskeletal system. As far as neurologic goes, testing cranial nerves and noting any deficits or lack of deficits. Don't forget to note lack of, okay? Because if you're doing your cranial nerves and everything's normal, don't not document that you did it, because this gets you bullet points, okay? If you're doing your deep tendon reflexes, and then if you're doing any of the touch or pinprick or vibration sensations, those count for neurological also. Psychiatric, describing their judgment and insight, their orientation to time, place, and person, remote and recent memory, mood and affect. I always click on this one. I like to document that they're either having or not having pressured speech, if they're tearful in my office, if they seem anxious, or if they seem depressed, or if they have no eye contact. That's going to be huge for your psychiatric skills. And then documenting that they're not homicidal or suicidal behaviors in your room. So the next thing, and I think probably one of the things that we can struggle the most with, is this medical decision making. It's kind of gray, okay? As far as I can count how many bullet marks I got on my physical exam, the biller or coder can't always read my brain as to what was going on for my medical decision making. So for medical decision making, there's 3 parts that are looked at for it. We're looking at what are your diagnoses and problems, what was the data that you reviewed, and what is the risk of the patient. This section uses a point system to determine overall complexity of the medical decision making. So I'm going to start first with the diagnosis and problems. So I'm going to first start going from the bottom and work my way up. So if I have somebody with a new problem with additional workup, this would be somebody who has a breast lump that's going to need a new mammogram and an ultrasound done. The diagnosis and problem section, the maximum points that you can get in this section is 4. Okay, so if you have a new breast lump or a new testicular lump, or something that you're going to have that's a new problem that's going to need to be worked up further, all you need is one diagnosis for the day, and you've got your 99214. Okay, because that's worth 4 points all by itself. Now, a new problem without any additional workup, I found you to have hyperlipidemia today. I'm going to start you on medication, but I'm not going to do any other testing with you until I see you back in your 3 months. That's going to be your new problem with no further workup planned. Okay, there's a maximum of 1 of these to be counted per visit. Okay, and that gets you 3 points. As far as an established problem that is worsening, I mean, who hasn't had a diabetic patient who went from an A1C from a 6.4 to a 7.9%, or your COPD with an acute exacerbation? That would be your established problem worsening. And there is no limit on how many of those that you can choose, but again, they're worth 2 points each. So if you have a diabetic who's worsening, who's having a COPD exacerbation, or if your A1C is up, probably your cholesterol panel is up also. And so if you've got those 2 chronic issues that are worsening, there's your 4 points to get your 99214 visit from that. Your established problems stable or improving, those get you 1 point apiece. That's your hypertension who's well controlled on your hypertensive medications. Your cholesterol patients who are controlled and such. And on your self-limited or minor, this is going to be your sprained ankles, your sore throat, streps, your flu. Even if you don't do anything, or not much of anything, they're going to live through it. Okay, so self-limiting or minor problems are worth 1 point each. And again, those can only be a maximum of 2. So you can't say that they've got bronchitis, and they've got strep, and they've got otitis media, and so if they have 4 small minor problems, you can only count 2 points for that. Data reviewed. If you want to count the points for this information, it has to be documented in your note, not just in a telephone note, not that you just spoke with a cardiologist, but it has to be written in your note. So when I do this, if I'm following up with, if I'm calling the cardiologist to discuss stress results, I'm actually writing in today's note section, I spoke with Dr. Porgolsky, cardiology, regarding patient stress test. And then if I want to write something else, I can, but literally that's all you need to write to show that you have discussed a test with the performing physician. You cannot just document that you reviewed old records. You actually have to write a summation of the records reviewed. And this may be easy if you're reviewing a couple of colonoscopies or a couple of CT chests, not so much for that full medical record that we're usually getting, okay, when somebody comes to us as a new person. Because like I said, you cannot just write reviewed records, okay? You're gonna have to write out the summation for it. The next thing I'd like to talk to you about on this is if you order an EKG and you're the one going to be interpreting it in your office, which I think that's probably what most of us do. I also do spirometry testing in my office that I'm interpreting. If you look on here, you can get points for ordering us. Under the 3rd line down is your EKG. It says PFT, but spirometry also falls into that. So I can get a point for that. And then I can get 2 points for independent review of my image or tracing or specimen. And so the important thing to note with this is that if you're going to do that, you have to document in your note. I know on my EHR, under my EKGs, there's a little place where on the EKG itself, I can write my interpretation. That's not enough. You actually have to have it documented in today's note. So I have a little smart phrase and it says, EKG done in office today. My interpretation is normal sinus rhythm, rate 86, no axis deviation, no bundle branch block, no QT prolongation, no acute ST changes. and no available EKG for comparison, or compared to old EKG dated, June 14th, 2019. Making sure that you have that documented in your note so that you can get the points for this. As far as I'm concerned, I think this data reviewed is probably the hardest section to get that maximum points of 4 on. I think that's just, most of us aren't doing that. I'm going to get me a point for reviewing or ordering my labs or reviewing and ordering an x-ray. But unless I'm doing those EKGs and, evaluating them in my office, I think this is the one that's the hardest to get 4 points on. So here's our table of risk. I know it's kind of a busy slide there, but I highlighted the ones that kind of give me the best idea of, okay, here's my table of risk. If you look at this, on your minimal risk, that's going to be your 99212 visit. Okay, your low risk is going to be your 3, your moderate is your 4, and your high risk is going to be your 5 level visit. For established, we'll kind of talk about the new patients here in a minute. So if you're looking at a 99213 visit, 1 or 2 of those stable chronic conditions, okay, or if you're prescribing them to take a leave after they hurt their knee. That's it. That's what a 99213 visit is, okay? To get a 99214 visit, I know we talked a lot earlier about the HPI and my little thing. If you are documenting all of those, location, duration, and all of those, that's going to get you the information for that. But here's the key to where most of us in primary care are going to be able to get our 99214 visits is 3 or more chronic stable conditions. Okay, so I don't know very many patients who don't have diabetes, hypertension, hyperlipidemia, and do you know that morbid obesity counts as one of your chronic conditions too? So even if they're coming in and they have high blood pressure and high cholesterol, if they're overweight and obese, you can document that, and that can be counted as your 3rd one, okay? So 3 or more chronic stable conditions, or 1 or more chronic conditions with an exacerbation, okay? So that's pretty easy to find this time of year when we're in the mid-allergy season and we've got our asthma and COPD patients. So it only takes 1 worsening condition to get you a 99214 visit. Prescription drug management is also in this. So if you have a diabetic patient who you're giving metformin to, that right there, that also pops them into that moderate risk section. For your high risk, if you've got a chronic illness with a severe exacerbation, that's going to be into your 5. If somebody's actively having an MI in your office, or if they are actively having a PE, that's going to be a higher risk. Or if they have any acute changes to their neurological status. I was fine yesterday and now I can't stand up straight. I'm falling to the right. If they're having TIA symptoms or that acute weakness, those are high risk categories. And so you're going to want to make sure that you're documenting that. I've got a bunch of other things, but those are the things I think in primary care, these are going to be the easy things for you to find and to see that are going to show you which category you can be in. And just so you're aware, it only takes 1 item from the table to qualify for your higher risk. So if I have somebody who is exacerbating with their COPD, but like I said, I only had, no other issues with, they also had a sore throat. The sore throat would be under your low risk, but as soon as they had that COPD exacerbation, that's going to bump them up to the next risk. Okay. Or if someone with cholesterol, and normally you were giving them over-the-counter fish oil, and now you're going to be prescribing Lavazza. That's now bumped you up to a prescription drug management, and so you're bumping them up to the next level. So bringing it all together, I'm going to display this in 2 different formats. Depending on your learning preferences, you're going to love one or the other, but not both. Okay, so I'm going to write this out for you in written format, and then I'm going to have it in a nice little table because I'm a table kind of girl. So For an established patient, 2 of the 3 components must be met or exceeded. Now, I don't know if you can tell I wanted you to note this. I have it bolded, I have it written in, large type, and I have it underlined. One of those 2 components must be your medical decision making, okay? If I answered all of those questions in my HPI, and I know I met a 99214 on that, and I met all of my 4 points on my reviewing my labs and my x-rays and EKGs and whatnot, but my medical decision making was not a higher level care, it doesn't count. You have to go down 1 level, okay? One of those has to be medical decision making. I think that was one of the things that I struggled with the most, because on my EHR, I have this nice little wand and I can click on it and it tells me what it expects it to be. And all it does is look at, did you reach 2 of the 3? Okay, so it doesn't count the fact that it has to be a medical decision making. So a lot of the systems, the EHRs, have those little wands where it, kind of judges your billing and coding based on what you've done. So just making sure that you're noting that one of those has to be medical decision making. So for on a new patient, all 3 of them have to be met or exceeded. So if one of them is only in a 99, if it's in a level 3 versus a level 4, you're going to have to go with that level 3, because all 3 of those have to be met to be able to reach it. So the question is medical decision making the same as differential diagnosis? No. The differential diagnosis does not play part into that. It obviously helps where your brain is going to where they can look and see, okay, I see that, but that does not technically fall into that. Only in those categories on that screen I had before will fall for you there. So here's the written out version of this. So for your level of history, to get a problem focused, which is going to be an established 212 or a new 201, you have to have 1 to 3 elements of your HPI or a status of 1 to 2 chronic medical conditions. And that's it, okay? I'd hope that none of you are doing 212 or 201 visits in this room. For your expanded problem focused visit, which is what I'm trying to get people out of, because I know when I was in school, they said, oh, well, your bell curve should be a 99213. You should not be doing 99214 visits or you're gonna get audited. Guess what? I hardly ever do a 99213 visit and I don't get audited because I have my billing and coding charted appropriately. But for a 213 visit, this is how little work you have to do. 1 to 3 elements of your HPI, which I think we're all going to be getting easily. The status of 1 to 2 chronic medical problems. And to get a 3, you have to put in 1 review of systems. Okay? So I want you to notice how little you actually have to document to garner a 214 visit. Just tell me during your regular visit, you aren't doing this much anyway in primary care. I understand specialists are way more focused, but normally in primary care, we are all over the board and they never let us get away with just addressing 1 item at a time. So for a 214, you have to have 4 elements of your HPI. Again, that's your knee, right knee, hurt it stepping down from an elevator, stepped off wrong, and it's achy, burning, and it's a 5 out of 10. There you go. There's your 4 elements of your HPI for an acute, or again, status of 3 or more chronic conditions, and they can be stable. In your review of systems, again, 2 is the magic number, okay? And then for a 214 visit, you have to at least document on 1 history issue. And like I said, with most billing and coding EHR systems, you're not even going to be able to finish your note without documenting on that. So if you look at it, what it takes to get a 5, it is significantly more work than what it is to get a 4. That's why we don't do those as often. Same thing goes for 4 elements of your HPI or the status of 3 or more chronic medical conditions. Where you're going to be able to get a 215 visit is doing more of that review of systems. You're going to need to have 10 systems, okay? And again, when we talked about that earlier, you cannot have palpitations and chest pain. That's 1 system. Okay, but if you have shortness of breath and chest pain, those are two separate systems. And so that's how you have to look at that. And most of your systems, if you're on EHR, are going to have the different elements separated for you. And then for that, you also have to have 2 of your 3 histories documented to get a 5. So here's your level of physical exam. For your 212 visit, you need 1 to 5 bullets from any organ system and a limited exam of the affected area. So that's your person who's only coming in for the sore knee and you're only addressing their knee and you're not listening to their heart or lungs or belly. For your 213 visit, 6 to 11 bullets from any organ systems and a limited exam of an affected body area or organ system or other symptomatic or related organs. For your 4, 12 bullets from any organ systems, okay? And then an extended exam of the affected body areas or other symptomatic areas. For a 5, this one's a lot different. So this one, you have to have 2 bullets from each of 9 organ systems. So for the above ones, from any, so I apologize, I stated that incorrectly. You can have chest pain and palpitations and lower extremity swelling. So that would be 3 just from that one organ system. You have to have 12 from any organ system to get you a 4. But if you're trying to get a level 5 visit, then you're going to have 2 bullets from 9 separate systems. And in my generic physical exam, I hit 13 bullets. That's mine. You know, when you build your regular physical exam so that you document what you do, I do the same physical every time on every person, and I know I'm consistent with that. So for your overall complexity of your medical decision making, again, 2 out of the 3 qualifying components are required for any given level of medical decision making. And here, this is going to fall into your problem points. If you're looking at the right side of the screen, it shows where we're looking at for moderate is going to be your 214 visit. And so you're going to have 3 problem points, 3 data points, and a moderate risk, okay? So the next 2 slides I think are worth printing out. This is the table version of what we were just talking about. I like to give this to our new employees that come into our office, and I have them put it right by their desk. I have one for established patients and one for new patients, and it tells me right here to get a 214 under my HPI, I need 4 or more HPI or 3 or more chronic conditions. I need 2 to 9 of those separate systems for my ROS and 1 pertinent family history. For my physical exam, I need 12 bullets from any system. My medical decision making needs to be in that moderate section. My problems need to be 3, my data points need to be 3, and my risk needs to be moderate. So I think that this is all in one slide, a nice, easy thing. Whether you're new, whether you're established as a primary care provider, I think these are the most helpful things. Spent a lot of time trying to get that together and make it look good. I'm a visual kind of gal like that. So this is the one for the new patients. So let me talk to you about the 99211 and 99201 visits. We should not be doing these as providers. These are nurse visits. Okay, examples of these would be a blood pressure check, a dressing change, allergy injections. If they're coming in for a Tdap or a flu shot, that's when you can bill for a 99211 visit. Diana, the slides are up on the website of AMNP. So the next thing we're going to talk about is coding based on time. When you're coding based on time, you must spend the allotted time face-to-face with the patient, and over half of that time has to be devoted to counseling or coordination of care. For this, in your note, you have to document how long the visit was and how much time was spent counseling and or dedicated to coordination of care. So on my note, I will write a total of 45 minutes was spent face-to-face with the patient today. Of that, 30 minutes was spent counseling on, and then I write a short description of what I spent my counseling time on. To be noted, if you're billing based on time, all of that other stuff we talked about with your HPI bullets and your review systems, those do not have any counting towards this. So no specific documentations required for history, physical exam, or medical decision making are needed if you're billing on time, okay? Just as an example, 2 weeks ago, I spent 45 minutes trying to line out a suicidal teenager to get into an inpatient site. I was on the phone with 4 different hospitals. I couldn't count this towards my time because I wasn't face-to-face counseling with the patient. I spent an hour and a half trying to take care of that patient, but I couldn't bill based on time because it wasn't spent face-to-face. I just want to make sure that we're clear on that this has to be face-to-face time with the patients, documenting and counseling. Examples of counseling items, so going over diagnostic results, prognosis. I mean, if you're sitting down and changing somebody over to some palliative care or hospice, I mean, that's where you're going to want to bill for time. I do this a lot with my diabetes patients. If I'm going to be starting somebody on insulin, or if they're just a brand new diabetic and they have no idea. I have worked rural health for 13 years. I'm now not rural health this past year, but I've been in rural health for 13 years where we didn't have a diabetic educator at all. And so I did a lot of this. And so I was able to bill on time. I also did a lot of this with my COPD patients. All of the providers in our group referred their COPD patients to me. I did all their spirometry testing and went over all of that and talked about medication options, and all of that's important time to do. And so I always try to make sure that I am, if I'm going to be doing a visit like that, I'm trying to make sure I have the time for it. I'm like, okay, I know I just saw you yesterday, but I got your labs and I need to see you again today. And I take that time and I make sure that we are bringing them back in so that I can bill for a visit and getting them the education that they need. So here's the table for coding based on time for your different levels. So whenever I'm coding based on time, I'm normally after a 215 because I can easily get a 214 all on my own just by my documentation. So if I'm looking for coding based on time, I'm usually spending 40-45 minutes to an hour with that patient. And so it's pretty darn easy to get a 215. And if you have your documentation, billing and coding specialists who are reviewing your paperwork are not going to question it if you have that one sentence that I had written out for you. So why do we care about this? Current charge at my office for a 213 visit is $130. A 214 is $192. That's a difference of $62 in one patient. I see about 15 patients a day. That's just short of $1,000 a day that I would be missing out, okay? I work 4 days a week, so that's $3,700 a week that I'd be missing out. And I work about 48 weeks a year, so that's $178,000. I think you guys are probably doing the skills and the evaluations on these patients. We just need to get it documented, and I hope that I've shown you how easy that is. So let me see if you guys have any questions on this part 1. I don't want you to fall asleep yet because I have a bonus part 2 section, okay? Let me check in this chat. I don't know how to check the chat. Does anybody here have any questions? Yes. Okay, so the question here is, if you're giving a B12 or an allergy injection and the nurse is seeing it, what kind of documentation needs to be done to be billed? So for starters, make sure that you can bill for it, because if you're a rural health clinic, you cannot bill for it. Okay, so that's the first thing. Like I said, I used to be rural health. So if you're rural health, you cannot bill separately for that. But as far as it goes, they would need to be able to document that they monitored for the patient and there was no sign, no reactions or anything like that. But your issue is probably more likely that you're rural health and you cannot bill for it. Okay. All right. Let me see if I can find. All right. Is Derek around? Let's see. All right. Oh, great, Beth. I'm glad I answered your question. Thank you. All right, so I'm going to go ahead and move on to part 2. So now that we know how to bill, yes.
So we had that patient that's really sick in our office and we feel that we're having a random bill in our line. We still don't get paid. Because I'm told we don't get paid in the office.
Okay, so the question is if you're seeing an acute issue patient like a suspected MI or a suspected PE, if you're seeing them near visit and then you send them to the ER, are you getting paid for that? So I believe that the higher level of coded visit, which would be your emergency room visit, would be the one that would take over for that day. It used to be he who got it in first, but it's no longer that. So the next thing I want to talk to you about is high risk weighting and coding, and what's that about? I mean, we've all heard of the HCC codes and our RAF scores, and I think that it's really important for us to understand what that is. This goes along with our Medicare Advantage programs, and Medicare CMS has taken 70,000 diagnoses that are in the ICD-10 book and decided that 9,700 of those codes are worth counting as far as making an increased risk to our patient population. And then out of those 9,700s, they've blocked those down to 86 conditions that they feel are going to be worth mentioning. So the RAF score, which is our risk adjustment factor, takes ICD codes and filters them into diagnosis groups and then into condition categories. They assign a weight value to each condition category, and this is used to calculate the expected cost each member is going to incur the next year. So how much money is Medicare going to give you to take care of this patient? So the RAF is determined by a baseline demographic element. So this looks at the patient's age, sex, are they dual eligible? Are they Medicare, Medicaid? When did they go on Medicare? Was it for age or for disability? And if the patient resides in community or if they're institutionalized. So Medicare does that part. You don't have to do any of that. They automatically give a score for that. And then the other thing that is determined in this is the weight of the diagnoses given in the previous calendar year. So we're working backwards on this. I'm sorry I'm bringing you math, guys. So the risk score is their demographic plus their disease weight of each condition that counts of what you bill for. And like I said, this is perspective in nature. So what you bill this year is going to affect next year's RAF score. So how much does the government pay? So they do this by county. So they somehow have a determination. They have this great big spreadsheet online called a rate book. County rate usually runs between $800 to $1,200 a month, with urban areas carrying higher amounts. So your county rate times your RAF score equals how much monthly capitation you're going to get. So here's your disease burden. So you have to report unique diagnosis codes at least once per year. Diagnosis can be captured hospital inpatient, hospital outpatient, physician or provider medical records. Cannot be done if somebody goes in and gets their labs and the diagnosis code is on it. That doesn't count. Doesn't count if they're in for chemo or dialysis or skilled nursing facility. So if they're being seen and you think, oh, well, you know, they got billed for their labs, I know that that diagnosis code was on there, it doesn't count. It has to be face-to-face. So for this, you must meet MEET, okay? The M in MEET is monitored. So this is going to be your symptoms, disease progression, ordering tests, referencing labs or other tests. Your E is evaluated. So test results reviewed with patient, medication effectiveness, physical exam findings, wound measurements. Those are all going to be under your E for evaluated. You're assessed. Examples, discussing and reviewing records, counseling with the patient, acknowledging, documenting status level, the level of condition. Do you have decreased sensation by monofilament exam? Another thing you can do for this is, this condition is managed by Dr. Jones, endocrinology. That counts, okay? And then T is your treatment. So this is prescribing new or continuing medications. surgical or therapeutic interventions, referral to a specialist, and then plan for management of condition, no complaints or symptoms, controlled on current medications. As easy as that. So I have an EHR dot phrase for all of my chronic conditions. I type in dot TLAB chronic and it pops this up. And so I'm getting credit that I either discussed or ordered labs. And then I make it to where I cannot bypass this. I have to stop on this and choose whether the condition is stable, new, improving, worsening. And then I say continue on metformin 500 milligrams twice daily, or you can change this as needed. We'll add Januvia, or whatever the case may be, or we'll now need to refer to endocrinology. You can add your increased dosages, add increased medication regimes. And that's what I document under every single one of my chronic conditions under those 3 that I need for a 214 visit. So here is just an example of that demographic weight examples that Medicare is doing for you. You don't have any part of this. I'm just trying to show you the difference. So age and sex influence a patient's health status. On average, older patients require more care. And in most cases, but not all, men require more care and therefore more financial resources. That's why age and sex are both variables. Full benefit dual eligibles are higher likelihood to be needing more care also. So if you look at this nice 70 to 74-year-old range, your female who lives in the community has a score of 0.38. Your male has a score of 0.39. So not a whole lot of difference, but the men do get you more money out of that. Now, that same person who's institutionalized in a skilled nursing facility or a nursing home, 1.15, just because they're in the nursing home, okay? So I have a whole lot of slides here for you, and I'm not gonna, zimmer through all of these. I'd just like to take a look at a few things here. Look at the difference in an HIV patient that lives in a community versus institutionalized. For their score, that community-based person has a score of 3.35 versus an institutional is a 1.71. Now, if you look at the lung cancer patient that lives in a community versus the institutionalized, it's actually quite the opposite. That is because they are going to be having more controlled medication regimens and more controlled follow-up versus your little lung cancer patient who's sitting at home, who's too sick to get out, or whose family member isn't coming and checking on them. So they're more likely to end up hospitalized in the ICU than somebody who's in the nursing home, who's having somebody have eyes on them, multiple times during the day. Here's one that I think is really, really important for us to notice. Let's compare diabetes without complication. I don't know how many of you guys have those, but I don't hardly have any diabetic patients with no complications. But if you look at that compared to those who have complications, and we're looking at a difference of a score of 0.1 versus 0.3. Okay, when we're starting to add this up, and I'll show you how this money makes us a difference in the end, you'll be able to appreciate how much this is. But I just want you to notice it's 3 times more risk if they have complication. And it doesn't matter if it's an acute complication or if it's chronic kidney disease kind of a thing, okay? And then when you're documenting your morbid obesity, make sure that you are choosing codes with both a BMI and a morbid obesity together. You can't document one without, you won't get credit if you don't document both. And then the other thing I'd like to note is your underweight patients, usually your elderly population, especially those COP or emphysemas. If they are underweight and you're documenting that, if their BMI is under 19 and you document underweight, you get 0 points, okay? Now, most of those patients are probably protein, calorie, nutrition deficit. If you take a look on this, that score is 0.49. That's almost a half a point for a documentation of protein, calorie, malnutrition versus underweight, okay? Here we go. On the next one here, don't forget those inflammatory bowel diseases like Crohn's and ulcerative colitis, end-stage liver disease, and a community-based patient that is dual eligible has a really high score too. So just being conscious of, a few of these. Documenting drug and alcohol dependence, except cannabis, okay, should be done. I mean, you're getting a 0.34 out of those scores also. And then if you look under here where it says HCC 47 diseases of immunity, I went, what the heck is that? So I had to go and look that up. This is not something in primary care that you're going to be diagnosing, but it is something that you can carry over usually from a cancer specialist. It's an anti-neoplastic chemotherapy-induced pancytopenia, or your agranulocytosis secondary to cancer chemotherapy. So not something in primary care we're going to be doing, but I mean, look at that score. It is huge. So I just want to make sure that we have, those kind of things noted in there. Psychiatric disorders have heavier weighting when the patients live in the community versus being institutionalized. Again, they're more likely to be non-compliant with their medications at home versus if you're in an institutionalized facility, somebody's making sure you're getting your medicine every day. Okay. Spinal cord injury ranks a 0.5, but if you're noting the patient to be a quadriplegic, that increases that score to a 1.3. Okay, so just being smarter with that. And then let's see here. I don't think there's any big ones on here. Seizures, make sure you're documenting your MS and those kind of things. I want to document in this one, tracheostomy status, okay, is huge. And if you take a look at that one, we are looking at a 0.98 on that. And then unspecified angina versus unstable angina is going to be huge. And then, like I said, I've got a whole bunch of them for you. Dialysis status and acute renal failure, and then looking at stage 3 versus stage 4 or 5. So making sure that you're updating that diagnosis with new labs each time, because your 4 and 5s get you a lot more money than your 3s. Major organ transplant or replacements are going to be important with that. You can document that they're seeing Dr. Daniel's nephrology for follow-up yearly. For your artificial openings, making sure you're documenting no sign of infection at the ostomy site. And that, with Medicare, if you don't document that they still have an amputated left lower extremity, Medicare assumes it grew back. So, and then if you have more than one diagnosis in a category, there are some weighted combination codes there for you. And then on here, I want to just make sure that I show you the most underdocumented and most overdocumented codes, and then commonly overlooked codes. And then I'm going to real quick, I know I'm running out of time, get into why this is important. So I'm going to give you this patient. She's Cora. She lives in St. Charles. She has a county rate of $1,000. She's 73-year-old, lives at home, eligible for Medicare due to her age. Her healthcare provider she saw this year documented that she had uncomplicated diabetes, she was underweight, bipolar, essential hypertension, and angina unspecified. So for exchange for you seeing that patient, they're going to give you that $1,000 for her county, 0.451 because of her demographics, and then the following 3 scores as the sum of her RAS. So that's $1,000 a month. Year 2, she goes to another provider who's a little bit more diligent with her coding. She is now 74, still in that same age group. She has been noted to have diabetes with chronic complications. She has protein calorie malnutrition instead of being underweight, bipolar, essential hypertension, CKD level 4, unstable angina. Oh, and she had an amputated toe 10 years ago. Okay. In exchange for that, if you add this all up, $25.96, okay, that's almost 3 times as much money. So what we see here is that the first provider did not document any chronic kidney disease, and I'm telling you that if she's stage 4 now, she probably was stage 3 last year, was diagnosed as underweight, even though she had her toe amputated 10 years ago, it wasn't documented. And with just a small amount of notation, changing that diabetes to chronic and noting that she had the CKD, noting the calorie malnutrition, and the amputated toe, it really increased that RAF score. So if you look at this, I mean, we're talking a difference of $18,000 in a 1-year period just for, making those more specific diagnoses. This is 2 different capitations, yet you're expected to take care of the same patient the same way. So, making sure that you do this. And that's on one patient. I mean, can you imagine 25 patients out of your whole year and you're going to bring in $470,000 more? Okay. Anybody still awake? Sorry. Yes. So you have to meet. Okay, you have to have it documented in your note. And, oh, I'm sorry. So she asked, can it just be the problem is current in the chronic problem list? And the answer is no, it has to be documented once per calendar year. Derek, can you come help me pull up and see if anybody online has any questions? Yeah, they're on the AMNP slide thing.
The most recent one is probably not. So.
The only thing not recent on it doesn't have my email, and that was it.
Okay.
Okay.
Nope.
So dual eligible is if they have Medicare and Medicaid. Okay. So it is for the Medicare Advantage plans. If it falls for acute care or not, I don't know that answer. This is more of from a primary care standpoint. So let's see here. Let me look back at any questions here. Sorry. Okay.
Hang on a second. Let me grab this.
Okay. So one of the bonuses about that RAF scoring and why we want to have those higher level of codes is because if you're getting $170,000 a year on this lady and she doesn't ever go to the hospital and she only comes and sees you 3 times, any of that money that's left over gets split between the provider and the insurance company. So you are more likely to get a bonus depending on what your healthcare provider group does. I know that with BJC, we get to have a part of that feedback if we don't spend all the money. The opposite goes the other way though. If you only got that, $1,000 a month on that patient and she ended up in the ICU, you're bottomed out and lost the other way.
So can those be documented by primary care or is it by
any specialist if you are in the same EHR? So if cardiology addressed all of their complex cardiology diagnoses, or if the oncologist diagnosed one of those other things, it just is looking at the whole patient. It's not just looking at what you're doing in your office. So it's total whole for what is being billed to the insurance company that calendar year. Okay, and again, it's working backwards. So what you did last year is affecting what you're getting paid this year.
Any other questions for Tammy? Folks here in person? Okay.
All right.
Function here real quick.
I just looked at that. It looks like we don't have any new questions there.
Okay.
All right. Well, thank you for your time.